Okay, so I'm going to try and power through some of these slides so you guys can get to your break on time. Sorry? You're fine. Oh, okay. All right. Well, I changed the title here a little bit. I was going to talk about advanced techniques in testing techniques in autoimmune hemolytic anemia. But I'm going to talk, guys, about just regular testing for wAIHA, and I'm going to talk a little bit about transfusions, okay? Those are the two things I'll focus on. These are my disclosures. I do get research funding from some of these companies here. I will not be discussing any off-label drug use today. Okay, so with testing, these are the objectives of my talk. I'm going to try and cover some historical aspects of diagnostic testing in AIHA, and then what we do for standard DAT testing. This, I don't need to tell this audience about, well, I'll tell you a little bit about DAT in the context of some of this testing, but everybody here knows what DAT testing is. Super Coombs test, some of you may have heard of it. This relates more to people who cannot be diagnosed immediately, and then they take a lot more blood and try to look for antibodies in their autoantibodies. And so there are different methods of doing that. I won't get too much into the details. And then you already heard from Dr. Hudson on how T cells affect antibodies and so forth. But her lab also does some cool research on what the subclasses of antibodies are that potentially are implicated in more or less hemolysis and so forth, okay? And then the second part is molecular testing or phenotyping before you get matched blood. And I'm sure several of you in this room have had issues with, oh my God, yeah, I have AIHA, and now I'm supposed to get blood, but my blood is not a match with any product that's available in the blood bank, right? And so what do I do next, right? That's often something that comes up. And I thought that, just providing a transfusion medicine physician's perspective here would help to see what it looks like at the other end and what you guys should be advocating for, in the unfortunate event that you have to go in and get blood, okay? And what is this whole, what is all the talk about? Let's do some genotyping and let's get genotypic information before we get blood transfusions and so forth, okay? All right, I won't touch too much upon the cold agglutinin testing. I'm going to be doing a virtual talk with the Caddy Chatter in later this month. So wherever there is overlap, I will mention some of the cold agglutinin testing, but mostly focus on wAIHA, okay? All right, so this is some history here. Obviously, all of you know autoimmune hemolytic anemia is because of increased red cell turnover through autoimmune mechanisms, and it's usually mediated by autoantibodies against the red cell surface antigens, okay? Now, believe it or not, the first case of autoimmune hemolytic anemia was actually described in the 13th century by a Byzantine court physician. His name was Johannes Actuarius, who observed black urine in a patient after exposure to cold temperatures. This case, most people think, was probably a case of what we now know as paroxysmal cold hemoglobinuria, likely secondary to syphilis or one of these infectious conditions. But the mechanism is more or less similar in that the patient has anemia, he's making black urine because there is hemoglobin and red cell loss in the urine, and when he's exposed to cold temperatures. So that's more of a cold agglutinin kind of picture. ABO blood groups, I have to tell you a little bit of transfusion history here. In the 1600s, people would do xenogeneic transfusions where people with conditions like syphilis, there is actually a description for those of you interested. Amazon has a really good book on blood transfusions called The Epic History of Blood. If you Google it, you'll find it. It's a brilliant read. I read it as a resident, and I really enjoyed reading it. But it's all about the history of blood transfusions. In the 16th century, physicians in the Parisian court that he describes in his book gave this patient with syphilis calming calf's blood, and then for a whole period after that, the patient didn't suffer syphilitic frenzies and therefore didn't beat up his wife, for a whole couple of weeks until the physician says he succumbed to his disease. Okay? But what he also says, the writer says, right after he receives calming calf's blood each time, he makes urine the color of chimney soot. Okay, clearly he's having hemolysis, like violent hemolysis, because he's getting xenogenic blood, which is not matched. Okay? And he has temperatures that are soaring through the roof, and he's like having rigors and chills and, all classic for a hemolytic transfusion reaction. And then he becomes calm and sleeps for days after that. Okay? His wife was happy, obviously. And then they realize, potentially, if he really was, not, beating up his wife during that period, that the heat-sensitive treponemes, which are the organisms that are implicated in syphilis, were probably being killed off with the high temperatures that he was experiencing from the mismatched blood that he was getting, and the body was just reacting violently, sort of like an autoimmune disease where the body is, but this is not really autoimmune. It's like, why are you giving me blood that is not mine, or that is not even in the same genetic makeup as mine, Anyway, so that basically banned blood transfusions by the Parliament of Paris and all over the world for the next 3 centuries, okay? And then in the 1900s was when Karl Landsteiner discovers cold agglutinins, but before that he discovers ABO blood types, in Austria and Germany. And that's when people realize, wow, you can give type-matched blood and people actually have increments without there being antibody-mediated destruction. And these are alloantibodies. Obviously, if you give a person who's A, B, even now, the one thing that blood transfusion physicians believe should be a never event, it's like operating on the wrong arm, is basically giving somebody out-of-group blood cells, okay? Which is why this whole thing comes up so often, that oh my God, it's not a perfect match. What do we do? Okay, but that's a whole different problem in autoimmune hemolytic anemias, and we'll talk about that more. But Karl Landsteiner then in the early 1900s discovers cold agglutinins, which are basically the antibodies that are binding to your own red cells and causing hemolysis. Interestingly, it was only in the 30s or the late 30s that people started to recognize that there is a partial antibody and a whole antibody. The whole antibody, which is the IgM, it's got 5 different arms, is the one that's implicated in cold agglutinin disease, and it binds it, and you see a whole bunch of clumps, and I'll show you that in the next slide. But it was in the 30s when Damashek and Schwartz postulated that there was an immune mechanism, and there were different types of antibodies implicated, okay? And that's what you see in this slide here. There's wAIHA and CAD, okay? With wAIHA, what happens is there is binding of an incomplete antibody, which means IgG, which can have 1 arm or 2 arms at the most, that binds to these red cells. And it actually doesn't activate this whole pathway called the complement pathway, which just basically annihilates the red cell, or it clumps and it breaks down all these red cells. Instead, it binds to these red cells, and then when the red cells pass through the spleen, it chews off bits and pieces of the surface of these red cells to a point where, some of you who are physicists or engineers in this room will understand that the red cell then tries to assume the smallest surface area. When more and more surface area is being bitten off, it's no longer biconcave, that beautiful shape that Dr. Hudson showed you earlier, because there's not enough surface area there. More and more is being chewed up, and so then it assumes what is called a spherical shape there. So in wAIHA, that's why they say there are a lot of spherocytes when you look at the blood smear, okay? And in CAD, there are clumps. That's because there are these IgM antibodies, which are bigger antibodies and more wholesome antibodies. They bind multiple red cells at the same time. And so the first thing that I tell my fellows is, as soon as you get a case like this, obviously the 2 things you have to do, any case of anemia, did you check a DAT? And 2, did you look at the blood smear? Because I think that can give you a lot of clues as to, First of all, is it some kind of autoimmune process based on the DAT, and then whether it's a warm or a cold, in addition to all the other tests, obviously, that we'll do eventually. Okay? And interestingly also, these same studies in the 1940s was when Damashek, who was a big hematologist, he in fact started the American Society of Hematology in the 50s. The proportion of the hemolysin titer, or what we call antibodies, okay, or the amount of spherocytes that you see in the blood was proportional to how high the antibody titer was, or the hemolysin titer was. Which basically says if you have more hemolysis and you're more anemic, you're likely to have more spherocytes because there's more antibodies binding to it, okay? So what about the Coombs test? Okay, that's sort of the hallmark. It's amazing that we have the Coombs test, guys, for wAIHA and CAD patients. ITP, which is sort of a sister autoimmune disease, there's no test like this. It's, we keep saying it's a diagnosis of exclusion. And I know some people in this room have Evans syndrome, where you can have ITP and or autoimmune hemolytic anemia. But we're thankful that we at least have some kind of laboratory test that we can use to say, hey, there's antibodies binding to my red cells. I may have an autoimmune condition. Okay? And this test was only discovered or only developed in the 1940s. Okay? And before then, all hemolytic anemia, sickle cell, you can have hemolysis in paroxysmal cold hemoglobinuria, infants who have congenital types of hemolytic anemias have different mechanisms, right? Whereas the Coombs test really helped us say, hey, this is autoimmune versus not, okay? And interestingly, in the 40s, these were made of rabbit antibodies. They were made by immunizing rabbits against human immune globulin, and that's what was called the Coombs reagent. And how this works is basically the patient who has autoimmune hemolytic anemia, and you take a patient who doesn't, potentially. Autoimmune hemolytic anemia patients have antibodies, autoantibodies that are binding to their red cells. And then you add what is called the Coombs reagent. These days, they're monoclonal antibodies. In the early days, like I said, they were rabbit antibodies, anti-human antibodies. You take these cells, you wash off these cells slightly because you don't want to get rid of all the antibodies. You just want to get rid of things that are just floating around in the plasma that may be loosely stuck there. You get rid of those. And then you add these antibodies against the antibodies that are bound already, okay? That's the Coombs reagent. And then when you spin it down, you can see these clumps that are shown there, if you have autoimmune hemolytic anemias. If there are no antibodies binding to the red cells, then adding anti-human antibodies will not really pick up anything on the surface because there's nothing bound there, right? When you've washed it off, it's all gone, and so you don't see any clumping. So then you say the DAT is negative, okay? So those are the two possibilities with this test. If there's antibodies binding, you'll see it positive. Now, of course, there's lots of reasons why you may not see it. Either the antibody binding was too little, or there was a different type of antibody binding that is not being picked up by the rabbit anti-human or the monoclonal antibody that you're using, right? Or they bound everything and they destroyed the red cells. So there's nothing there. There are no red cells in there that have bound antibody. Okay, so those are all the different possibilities why you could have autoimmune hemolysis but still have a negative test. Okay, same thing with cold agglutinin disease, except in cold agglutinin disease, you will see the complete antibody that I was talking about, or the IgM, which binds all those different cells and causes those clumps like I showed you in the previous figure. Okay, and that is because it activates complement. Okay. So those are complement binding. And why this is important is because, and I won't go through this in too much detail here, but I have had lots of referrals from the community where they will see that the DAT was positive, and then they won't look further in terms of, was it an IgG, which is more common in warm autoimmune, or the partial antibody, which is more common in the warms, versus the C3, which is more common in the colds. And that's critical because if you have very high levels of the complement, it's more likely that it's a cold kind of anemia versus if you have very high levels of the IgG, which is more the warm autoimmune hemolytic anemia. Why this is different is because treatments are different. We know that initially steroids work much better in the warms than they do in the colds. So that's a critical piece. I had one patient refer to me last week from Alaska, and the doctor said, well, he has cold agglutinin, and he was treating him like a cold agglutinin disease when he basically had just looked at his DAT and it was positive, and the patient said they were feeling cold. But you can feel cold because you're anemic. It's sort of the opposite problem of what somebody was describing earlier today. You can feel cold if you're anemic. And so this patient had very high IgG, which was more characteristic of the warm kind. And when I gave him a whiff of steroids, he improved immediately. And that's one of the reasons I also feel like these cases should be referred to centers for excellence, or we should be creating or looking at centers for excellence, because if I had 200 different types of patients to take care of, I would not know each time to dig deeper and say, hey, okay, the DAT is positive. Is it warm type? Is it cold type? Those sorts of questions. The titers matter. I always ask my blood bank colleagues, hey, was it a 1+? Was it weak, or was it really strong? And there were early studies. Nowadays, blood banks don't report it, but that tells me a lot. It tells me, first of all, if it's weak or not, is the disease really active? Sometimes it can give you that clue. I mean, it's not perfect in that 1 is not much different from 2 is not much different from 3. But if it's a 1 versus a 4, that's a big deal. Okay? So, because these are all very visual tests. The blood banker will add this Coombs reagent, and then they will look at it visually and say, oh, is there 1+ clumping, or is it 4+ clumping? And so it can change quite a bit. Inter-observer variability is obviously a problem, but anybody who looks at a 4+, and they have scales to look at it. There are pictures, visual pic cards, that'll say, oh, that looks more like a 4+, okay? So that is important in my opinion. And this is, again, the test like I was saying. There are number of antibodies bound to the surface matter. These are more advanced techniques that I mentioned, what we call super Coombs testing. For people who already have a diagnosis of autoimmune hemolytic anemia, you don't necessarily have to do these tests if your DAT is negative. For first-timers, though, where you don't know why they're anemic, there's all these different things going on, sometimes I do suggest doing some of these more complex ways of identifying antibodies bound to the surface. The caveat, though, is that this needs a lot of blood. You sometimes have to take 50, 60 mLs of blood. I mean, in an anemic patient who has a hemoglobin of 6, that's the last thing I want to do. So what do I do then? I just empirically try to treat with some steroids and see if there's response, okay? Sometimes, and I'm not talking about 8 months of steroids, guys, okay? I know some people are cringing here. Oh my gosh, she's just like throwing steroids at everyone. No. In fact, that's one of the things that I am a strong proponent of. When are we going to second-line therapies? When are we calling those guys in the back of the room to say, hey, where are those immunotherapies? I want to move these patients out of getting steroids, right? But believe it or not, the tests are still imperfect enough that we rely more on treatments to help us with the diagnosis than we can on the actual tests themselves, okay? So sometimes when the patients come to me and say, well, you don't even have a diagnosis, why are you giving me steroids? Because if you respond to steroids, I can work backwards and say, maybe that's the diagnosis, okay? All right, and then these are some other, it's the same super Coombs testing. There's more fancy ways of saying whether it was a particular type of immunoglobulin which is not picked up by regular DATs. In fact, I'll just show you the image, but this is basically some fancy stuff that Dr. Hudson's lab is working on in terms of immunoglobulin subtypes, because there are certain, like IgG1 or IgG3 may cause more hemolysis versus others. We don't know what to do with this information clinically yet, and we don't have good enough tests to say this is routinely. You can figure out if this person has an IgG1 or 3, maybe they're more susceptible to more severe wAIHA or hemolysis and so forth. We're just not there yet, okay? All right, that was the first part of my talk. How much time do I have, Karen? I can tell me how much, maybe 5-10 minutes? Okay, perfect. So I'm going to switch gears now and talk a little bit about transfusions. I mean, pretty much everybody in this room, has had to receive transfusions at some point, And one of the common problems, and now I'm going to talk with my blood banker hat on, is when you see a patient with hemolytic anemia, or take the blood from a patient with hemolytic anemia, and they say, well, the patient's hemoglobin is 6, they're extremely symptomatic, they're short of breath, okay, give us blood. So now I'm in the blood bank, and this is what I see on my testing. That last column basically tells me, this is like a Sudoku, guys. We all do this, which is we take your blood or your plasma, people who want to be transfused, we take the patient's plasma, we add it to blood cells of known antigen type. So we know what the surface antigens are on those red cells. These are all commercially available. We add the patient's plasma to each of these wells, and then we check off, did it react to this cell? Did it not react to this cell? Okay, and then we play a game of Sudoku. We don't play, but we take it seriously. But we do the same. It's the same method. We say, did they react to A, C, and D? Maybe they don't have this antibody. Did they react to cell 4, 6, 8? Maybe they have this antibody. That's literally what happens, okay? What happens, though, in wAIHA and CAD is we see that, which basically is all your cells are reacting, okay? Which means that there are reds. You gave me your antibodies. Something in your antibodies or some antibodies in your plasma are basically binding to all the red cells we're testing for. And, as a control, what we do is we take your own red cells and add your own antibodies. Normally, those should be negative because technically, you're not supposed to react to your own cells, right? Unfortunately, wAIHAs and CADs are unique because you react to your own cells. So now the technician will come to me and say, Doc, I have no idea what to do with this because I don't know how to give them the right match cells. I can give them RH, I can give them Kell negative, Duffy negative. And then he tells me, these are all the things that are available in our inventory, okay? So when you have this conundrum, sometimes what physicians do is they call the floor and tell the clinicians, hey, I'm going to send you least incompatible blood, okay? But I honestly, from wearing my blood bank hat, I don't like that term. You know why? Because you're either compatible or you're not, okay? There is no such thing as least incompatible, okay? It makes the physician feel better, okay? But what you don't know is everything is reacting there. I mean, just because one is a 3+ and one is a 2+ doesn't mean you're not reacting, okay? Interestingly also, and I'll just summarize this slide here, about 40% of patients, because you are transfused blood and you don't know the kind of matching that happens and you're also receiving blood transfusions frequently, you can form antibodies against the foreign blood that you're getting, okay? So that is why everybody is worried about giving incompatible blood, because you might form antibodies. The problem is the testing to make sure that we know exactly what your blood type is. And guys, blood type is not just your ABO type and your RH type. Okay, there's all these subgroups or what we call minor antigens. Okay, there's ABO, okay, which can all be different. Then there's RH, which we only test typically for RHD, okay? Then there's all these other RH system antigens that you have to look for. RHC, big C, little c, big E, little e. There's a whole slew of those. That's what that previous slide was showing you. Then there's Kell antigens, there's KID antigens, Duffy antigens, okay? All of these, to be able to test each of these and to figure out what they typically do, fancy blood banks get rid of all those stuck antibodies. They take your plain red cells or your antibodies and then they make serial dilutions. Sometimes they have to warm it and then they see which ones they react to, which ones they don't, and then they try to determine your phenotype or your particular type, which has all this information about all these different blood group antigens, okay? That whole process takes about 8 to 12 hours in advanced testing labs, okay? So when I'm in Seattle and I get a patient referral from Spokane, forget about it. I tell them, okay, you're probably not going to get testing back for 2-3 days. But I do not tell them you're not going to get blood for 2-3 days. Then I ask the clinician, well, what's the patient's hemoglobin and how are they feeling? If they say, oh, they don't feel good at all, they're extremely short of breath, I say, go give whatever blood you have that is at best O negative. We all know that O negatives are universal donors, but they might still not be perfectly matched for all those minor antigens that I was talking about. But go ahead and give the O neg. You know why? Because the worst kind of blood that you can give a patient is the blood, or they say the worst kind of blood that is transfused is the one that is not transfused, especially when they're anemic. Because the risk with all of these things is that there can be what we call delayed hemolytic transfusion reactions, typically. For if they're not ABO matched, they lyse immediately. But if there's minor antigen mismatch, they typically cause delayed reactions where you destroy it slowly or you destroy it after 10 days. Let's worry about the 10 days after the 10 days. Right now, if you don't get the blood, you're going to, have a catastrophic outcome. You need the blood now, And this is where, obviously, this is, an old Voltaire quote that says, don't let the perfect be the enemy of the good. And this is also from a paper from Dr. Paul Ness, who was a big transfusion medicine physician at Johns Hopkins in Maryland. He says this least incompatible doesn't work. Obviously, there is incompatibility, but if you need to give the blood, don't delay transfusions. And then the time, obviously, it takes a long time to do some of this testing. But if needed, you can ask 2 physicians to sign consent. If the clinician doesn't feel comfortable that they're giving incompatible blood, have 2 physicians sign consent and say, yes, this is the time to go ahead and give the blood. Because by the time you have a delayed reaction, we would have figured out what your phenotype is in about 10 days, and then we can give you better matched blood potentially, okay? There's different techniques to figure out your underlying antigens. Historically, they would do that complicated testing. These days, we could also do genotyping, okay, which gives you all this information. You see, the ones that are circled on top in green are the ones that are picked up by just doing antibody testing, okay? Whereas all those other antigen information you can get from doing genotyping, okay, which is molecular testing. Okay, but the real question is, what are we going to do with all this information, even if we get it? By the way, gene testing takes also 2-3 days to get this information back. And they can test it from any of your cells. They can get buccal swabs and test your genotype on the red cells. Okay, so, but then what are you going to do with all this? Are you really going to go after donors who are also genotyped, who have exact matches to all of these 350, 400 plus antigens and antigenic variants? I mean, that's, futuristic. I would love it if that happened, but then, what's the donor pool in your area? Have they all been genotyped? What are the implications for the blood bank who's doing all of this? We're talking about genotyping one of you, and there's talk that you could do genome sequencing with $100. And that's okay for a single patient, but what about all the other donors who you have to sequence, and what is the implication for blood centers? That's the other big question. How do you type all your donors? And even if you do, how many perfectly matched donors are really out there? We're not talking about a bone marrow transplant or a solid organ transplant where you go out of your way potentially to find that one perfect matched donor. We're talking about blood transfusions, 8 to 10 transfusions each time you need to go in potentially, right? And so that's the big question. And so believe it or not, blood banks are actually trying to do this. And guess what? This is the kind of storage space they need to actually collect genotypic or molecular testing information and store in these kinds of rooms of just data, okay? And even though this has turned to the size of a chip here, relatively speaking, this is how much space is needed to store, your molecular testing data from all the donors in a particular blood bank. Let's say the American Red Cross, they probably need a lot more, right? But this is how much space they would potentially need, but what are we talking about in terms of costs for testing all these donors, right? And so this is a great technology, but not all of our blood centers at this point are equipped to make these kind of investments, because it's not just investing in the technology. It's investing in trying to interpret that data. It's investing in trying to get our techs to be able to know how to match blood after that and say, oh, this patient in Alaska needs blood from that donor in DC because they're perfect matches, and then how are you going to get that blood? Doesn't that take 3 days, So there are all these different implications for lab information systems, the new skills and bioinformatic capabilities, algorithms for matching, and so forth. So I will like to finish by saying, don't let the perfect be the enemy of the good. If you're short of breath, if you feel tired, you need to tell that doctor and say, hey, give me whatever blood there is available. They will give you at least ABO and RH compatible blood, and then we can worry about testing over time. Obviously, there are downsides to a practice like that, but nothing is perfect. Even if you got the perfectly serologically matched blood, they're not molecularly matched. So that itself is a problem, okay? So, not to end on a grim note, but I do think I do think that it's important for all of us to be advocates, for our own, based on our symptoms, we have to say, hey, it's okay, I'm willing to take, I'm not saying, yeah, just give me any blood off the shelf, do your best, obviously, and match for the basic things that you would match, let's say, in an emergency situation, and then we can discuss more advanced testing, because unfortunately, there have been cases of death because the doctors have just been too scared to give blood that is incompatible. Okay. All right, and then definitely encourage family, friends to donate blood. I think, it's nice that the US is an all-volunteer donor pool. In countries like India, any patient who needs blood, a family member has to donate, and then they take a unit out of the blood bank. It's all tested, so it's not like you can get directed donations from your own family member. Sometimes that can happen as well, but it's all tested and so safe in the US. In some of these countries, you still have to donate to get a transfusion out of the blood bank. So I think we're really fortunate, so definitely refer people to donate blood. All right. Thank you, guys.